You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for November 12th, 2021. This week, left atrial appendage closure, TAVR versus SAVR, renal denervation, and an AHA preview. First topic is left atrial appendage closure. At the TCT meeting, Dr. Pavel Osmansik from Prague presented the 4-year results of Prague 17, a non-inferiority trial of left atrial appendage closure versus direct-acting oral anticoagulants, or DOACs, in high-risk patients with AF. Now recall that the original Prague 17 was conducted in 10 centers in the Czech Republic. About 415 patients were randomized, and last year, the investigators published results of the 21-month follow-up. These were about 72-year-old patients, CHADS VASC 4.7, Hasbled score of about 3.0, and the original trial design was of non-inferiority, and the non-inferiority margin was 1.47. The most controversial aspect of this trial was the broad composite endpoint that included both efficacy, stroke prevention, and safety bleeding endpoints. This creates a serious bias issue in non-inferiority trials because remember, in non-inferiority trials, no difference is a positive for the new therapy. And when you have parts of the composite endpoint that you expect to go in opposite directions, they cancel each other out, and it makes non-inferiority easier to reach. And this is exactly what happened in the 2-year results. There were 47 primary outcomes in the DOAC arm versus 38 in the appendage closure arm. The hazard ratio was 0.84, and the confidence intervals went from 0.53 to 1.31. And since the worst case scenario of 1.31 was less than 1.47, left atrial appendage closure was declared non-inferior to DOAC therapy. Now for the efficacy endpoint, stroke, TIA, cardiovascular death, and systemic embolism, there were 4 more events in the drug arm, but in the safety column of device complications plus bleeding, there were 2 more events in the device arm. In these 4-year results that were presented at TCT, the rate of primary endpoints was now 11.9% in the DOAC arm and 8.6% in the left atrial appendage closure arm. The hazard ratio was 0.81, and the confidence interval upper bound was 1.18, which again met non-inferiority. There were 13 stroke and systemic embolism events in the DOAC arm versus 14 in the appendage closure arm, so no difference. There were 40 bleeds in the DOAC arm versus 29 in the left atrial appendage closure arm, but there were 0 procedural complications in the DOAC arm versus 9 in the appendage closure arm, including 2 procedural deaths. The authors concluded that, quote, in long-term follow-up of Prague 17, appendage closure remains non-inferior to DOACs for preventing major cardiovascular, neurologic, or bleeding events. Furthermore, non-procedural bleeding was significantly reduced with left atrial appendage closure. So my comments and translation on this trial is that the author's first conclusion is technically true. It was non-inferior as they define non-inferiority, but the same existential criticism applies. You can't test non-inferiority this way. Non-inferiority should only be used if a new therapy offers some advantage, like safety or convenience or cost, over a new therapy. And left atrial appendage closure may do that with its purported but not yet proven ability to get off anticoagulation and have less bleeding. But the way you would test this is the same way DOACs were tested against warfarin. You first test non-inferiority in the efficacy endpoint of stroke, only stroke, not CV death. Then you test superiority and safety, which in the DOAC versus warfarin trials was bleeding. But in a DOAC versus appendage closure trial, safety would have to be bleeding plus procedural complications. If appendage closure was superior to DOACs in safety, and it was not worse in stroke prevention, you'd have a winner. But you clearly don't have that here. In the appendage closure arm, the total bleeds of 29 plus the 9 procedural complications is 38 events, and that's nearly the same as the 40 bleeds in the DOAC arm. And for efficacy, you basically have the same number of strokes in both arms. In the accompanying editorial, Dr. Faisal Merchant from Emory outlined 3 other important critical appraisal points. First, he pointed out that device-related thrombus and peri-device leaks are an Achilles heel for left atrial appendage closure, as these can increase stroke rates. These problems can present late after the implant, and when they're present, they increase the risk of stroke and require anticoagulation, which defeats the purpose of the device if you have to add anticoagulation. In PROG 17, the plan to transesophageal echo assessment at 6 and 18 months were not done due to COVID, which of course is no knock on the PROG 17 authors. But Merchant's point, though, is that this was a lost opportunity to learn more about these important headwinds for left atrial appendage closure. The second point Merchant made was he noted that 13% of those in the DOAC arm stopped taking anticoagulation, some for bleeding, but others for unknown reasons. But also, 9% of patients in the appendage closure arm were treated with oral anticoagulation at some point, some for DRTs or peri-device leaks, others for unknown reasons. This, of course, also is an existential problem for left atrial appendage closure because the whole point of the device is to provide stroke prevention without anticoagulation. If you start anticoagulation in a patient with a device, it defeats the purpose of taking that upfront procedural risk. You could have just taken the anticoagulant. What's more, consider that many patients who have left atrial appendage closure have it precisely because they bleed while taking oral anticoagulants. Now, if they then develop a device-related thrombus and have to take anticoagulation, you have put them in an even more precarious position than they were in before they had this foreign body in their heart. Third point Merchant makes is another problem with the composite endpoint, and that's asymmetry. In PROG 17, a 2-gram drop in hemoglobin is given the same weight as a stroke. Now, in the end, my friends, you must read beyond the headlines and abstracts. PROG 17 shows that the device does not reduce strokes, and if you combine the upfront risks plus bleeding, there is no safety benefit, certainly not superiority. It takes a mighty effective therapy to overcome an upfront major complication risk of about 5%, and in the real world approaching 8 to 9%. Thus far, left atrial appendage closure does not come close. Unless there are incredible iterative gains going forward, I remain unshaken in my belief that this procedure, percutaneous left atrial appendage closure, as it is practiced now, will remain one of our field's greatest mistakes. Next topic is the SURTAVI trial, TAVR. Also at TCC, we learned the 5-year results of the SURTAVI trial. This was of self-expanding transcatheter aortic valve replacement, TAVR, versus surgical aortic valve replacement, SAVR, for intermediate risk patients with symptomatic severe aortic stenosis. Now recall that the original SURTAVI results, published in the New England Journal of Medicine in 2017, found that the rate of the primary outcome of stroke or death at 2 years was 12.6% versus 14% TAVR versus SAVR. These results met non-inferiority. Surgery had more AKI, AFib, and transfusion requirements, but TAVR had more pacemakers and residual aortic insufficiency. These were 80-year-old patients in SURTAVI. At 4 years, the new data reports the Kaplan-Meier curves for stroke or death were nearly superimposable. 31.3 versus 30.8 for TAVR versus SAVR, and these were clearly similar results. There were slightly lower rates of stroke in the TAVR arm, but this did not reach significance. Pacemaker rates, however, 35% for TAVR, 15% for SAVR, highly significant difference. A valve area, slightly better with TAVR. Aortic insufficiency, more with TAVR. The KCCQ quality of life summary, no difference in long-term follow-up between the two groups. And the conclusions of the authors were that over 5 years, heart outcomes were similar. And I certainly agree with that. The Kaplan-Meier curves here with a self-expandable valve are quite similar to the transfemoral cohort of PARTNER 2A, the intermediate risk patients with the balloon expandable valve. Now, there are some internal validity concerns that have been discussed. That is, there were many more withdrawals and loss to follow-up from the trial in the SAVR arm. About 27% of the patients withdrew or were lost to follow-up in the surgical arm versus 11% in the TAVR arm, and I'm not sure I have heard an explanation for these disparities. There's likely nothing nefarious here, but when the paper is published, you hope that there'll be some discussion of how that differential withdrawal and loss to follow-up affects confidence in their results. Nonetheless, taking the results as they are, we can say that for an 80-year-old patient similar to those enrolled, the primary outcomes look similar, and since TAVR is less invasive, this seems a choice many patients would make. But for me, the entire issue of TAVR versus SAVR is the translation to younger patients. 1 in 3 patients in the TAVR arm of SURTAVI ended up with a pacemaker. That is not a big issue for an 80-year-old, but it is for younger patients. The presence of AI is also not likely an issue for an octogenarian, but it is for younger patients. Then there is the matter of longer-term follow-ups and valve durability. A 70-year-old with severe AS has to care much more about longer-term data, including valve durability. Just so you know, it's not some random podcast or electrophysiologist with these concerns about translation. In our news story, Steve Stiles cites the esteemed Harvard cardiologist and former ACC president Patrick O'Gara, who said, quote, "We need to be really cautious in translating these outcomes to younger patients at lower risk. Of the problems that we face, indication creep is close to the top of the list. Quote, I think it's not really fair for us to say 60-year-old patients will fare equally well, or that trade-off between a pacemaker implant and the need for repeat procedures is perceived the same in folks who are 15 years younger," end quote. Next topic, renal denervation. There were 2 notable studies on renal denervation to discuss this week. And first, a tiny bit of background. The idea behind renal denervation is by blocking neural activity from the kidney, you reduce blood pressure via a number of complicated mechanisms. Initial enthusiasm for renal denervation stemmed from non-controlled studies, but then a sham-controlled study called Simplicity Hypertension 3 found no significant effect. Now, though, through iterations of the device and procedure and more careful control of medications, renal denervation is making a comeback. I've previously discussed the Radiance Hypertension series of trials. In May of this year, 2021, Lancet published the 2-month results of Radiance Hypertension Trio study, in which patients with resistant hypertension were then given a 3-drug polypill. Now, more than half of the resistant patients were no longer resistant when given this polypill, but those that remained hypertensive were then randomized to renal denervation or a sham procedure. And in blinded follow-up at 2 months, the primary endpoint, renal denervation reduced daytime ambulatory blood pressure by 4.5 millimeters of mercury. At TCT, we heard the results of a second phase of this study from months 2 to 6. This was a pre-specified extension of the main study, and I have to say it was quite clever. I mean, patients and doctors were still blinded. So those who remained hypertensive were given, via a stepwise protocol, doses of first spironolactone and then bisoprolol. Now, the 3 main findings of this study, which was presented at TCT, were that 1, aldosterone antagonists were used in 40% of those who had the renal denervation, but 61% of those in the sham arm. And the sham control patients were on disproportionately higher doses of spironolactone. And the third finding was that home measured systolic blood pressure fell by 4 millimeters more in the renal denervation group, despite using less add-on meds, though there were no differences in the 2 groups in office blood pressure. Now, this study has not yet been published, and we'll need to see the paper, but it looks like there is a modest additive effect of renal denervation out to 6 months. And to me, the main take-home can be summed up in one modifier: modest. I'd say still nearly half of those who had renal denervation still required spironolactone. And the differences in blood pressure remain modest. Both groups get a huge effect from taking spironolactone, which is a heck of a lot less pricey and invasive than a procedure requiring femoral artery access. The second study, JACC Intervention, published a second notable study. This was a meta-analysis of the 7 sham-controlled renal denervation studies that have been published. Now, the goal of this meta-analysis was informing the effect of renal denervation in patients taking medications and in those not taking medications. The first author, Dr. Youssef Ahmad from Yale, but other authors included Daryl Francis, Deepak Bach, and James Howard. The 7 trials included about 1,300 patients and included different catheters, different types of patients. The overall mean effect on ambulatory systolic blood pressure was minus 3.61 millimeters of mercury, and there was no significant heterogeneity between the trials. The overall mean effect on office blood pressure was a bit higher at 5.9 millimeters of mercury. Again, no heterogeneity. And when the authors separated out trials that included patients taking meds versus those off meds, the reduction in ambulatory systolic blood pressure was similar at slightly more than 3 millimeters of mercury. And there was no evidence that the use of concomitant antihypertensive meds had a significant impact on the effect of denervation on ambulatory systolic blood pressure. They also found no effect of first versus second generation catheters, and complications were low. The meta-analysis authors concluded that renal denervation, quote, could be helpful at various points within the overall strategy of blood pressure management, including as an alternative to additional meds for patients with resistant hypertension already taking several medications, or as a first-line therapy for drug-naive patients with hypertension. So some comments about this combination study of multiple RCTs. The obvious and main point was that the extremely modest reductions of 3 to 6 millimeters of systolic blood pressure occur at 4.5 months follow-up. But my friends, you know, blood pressure management is for years, not months. While proponents will say, look, Mandrola, renal denervation is always on. You don't need to take pills. I would counter that we don't know if the modest reduction in blood pressure will last. And sadly, the authors point out that we aren't likely to find out, because trials require a strict protocol of medication and limited clinician freedom to make these dose changes, and that strictness is necessary to make precise estimates of the effect size. Quote, the way to truly assess long-term effects of denervation on blood pressure would be to have patients undergo a double-blinded, placebo-controlled procedure and be willing to remain blinded in the long term. Such an approach is impractical, end quote. Now pause there and think about the implications of the cost efficacy of this procedure. It might be very hard to ever get a handle on that without knowing long-term data. Now, Dr. David Kandarzi wrote the accompanying editorial, and he emphasized a couple of things. First, the difficulty in pooling such different studies. He noted that these trials had things like variance in blood pressure criteria, different procedural techniques, different follow-up duration, and different trial conduct. Kandarzi then points out the benefits of blood pressure turn on a lot of things, like the initial severity of blood pressure, the underlying cardiovascular risk and comorbidity, and the time within treatment range. His next point, though, I think is key. He pointed out the need for the ability to identify predictors of response. This is going to be so important because there are millions, zillions of patients with hypertension who, if offered a procedure rather than lifelong pills, would jump at the chance. I think we're going to need a lot more data on renal denervation, which is being gathered, and kudos to the researchers doing this. These early studies show a modest effect that seems present on or off meds. In my mind, there is a biologic effect that lasts at least 4 months. But in addition to the knowledge gained from further studies, I also wonder if this would be a classic case of looking for heterogeneity of treatment effects. Does age, baseline blood pressure, renin levels, for instance, do these things matter? I mean, to contain the cost of this procedure, we must find a sweet spot of who benefits most. Final topic is a brief AHA preview. The American Heart Association meeting will happen this weekend. Both Patrice Wendling and I have written preview columns, and take a look at those. The AHA meeting is going to be virtual, which is totally understandable given its large size and international nature. There will be a number of notable trials presented, and leading off is the AVATAR trial. This is the second RCT looking at watchful waiting versus surgical aortic valve replacement in patients with severe but asymptomatic AS. Last year, the South Korean recovery trial found surgical therapy far superior to watchful waiting. And if AVATAR is positive, the dogma of waiting for severe AS to cause syncope, heart failure, or chest pain, I think will be over. One external validity or generalizability question is, if the trial is positive, will it also apply to TAVR, since both of these RCTs studied surgical aortic valve replacement to watchful waiting. Another surgical trial, which shockingly does not have an acronym, will assess the benefits of tricuspid valve repair at the time of mitral valve surgery. It's currently controversial whether or not the added work on the tricuspid valve helps patients. The primary endpoint of this trial is tricky. It is a composite of death, reoperation for TR, or the progression of TR from baseline by 2 grades, or the presence of severe TR at 24 months. And I hope you notice the problem. It's that latter component, the degree of TR. This is an extremely soft surrogate endpoint, and TR is very, very difficult to estimate. So when assessing that trial, be careful looking at the components of the primary endpoint. There will also be numerous papers on atrial fibrillation. Dr. Greg Marcus from the UCSF is on the docket with 2 more elegant trials, one on, get this, caffeine and AFib. The UCSF group is really doing superb work in this area. There'll be another trial on curving post-cardiac surgery AFib, and gosh, we've struggled to try and limit post-cardiac surgery AFib. We finally get to hear the results of the AMAZE trial of epicardial left atrial appendage closure with a Lariat device as an add-on for AF ablation. The company has announced that the trial missed its primary endpoint, but I'm looking forward to the data. And my colleague at Medscape, F. Perry Wilson from Yale, will present an intriguing trial called REVEAL AF, which looks at the value of alerting clinicians about the prognosis of heart failure patients. I'm drawn to this trial because I think the prognosis of heart failure patients is both under and overestimated. I mean, so much emphasis in heart failure care is placed on guideline-directed medical therapy, and of course that's important, but sometimes I think we underuse arrhythmia and palliative care consultants. And there could be no cardiology meeting these days without SGLT2 inhibitor trials, and AHA will feature 2 more trials in that space. And finally, Mark Sabentine from Brigham will present the TIMI group's independent analysis of the left main PCI versus CABG trials, and that will surely be an attention getter. All in all, the Heart.org Medscape Cardiology team will be there to cover the meeting. These are great journalists, and they're doing important work, and I would recommend following them closely. So that's it for This Week in Cardiology. As always, I'm grateful that you listened. Thank you. And remember, friends, if you like this podcast, please take the time to give us a review, write us a sentence or 2, tell us what you think. These comments and ratings help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.